Hello, Blazers. Welcome to episode 138 of UAB Green and Told, originally released Monday, December 2nd, 2024. This podcast gives us a chance to share stories from members of the UAB community. Looking for past episodes of campus's most downloaded podcast? Find us at alumni.uab.edu/greenandtold on Spotify or the Apple Podcast app. And while there, leave a written review so more alums can listen in. I'm Greg Berry, a UAB alum and Director of Communications in the Office of Alumni Affairs. Today, we're thrilled to welcome Dr. Ginger Campbell to the podcast. A renowned physician, she possesses a deep passion for palliative care. As we'll discover, she believes that communication is at the heart of her care for patients.
Palliative care is a lot about communication, and that's kind of really what I enjoy the most about being a doctor is talking to patients and helping them make choices.
Throughout her career, Dr. Campbell has placed an emphasis on the importance of expressing concerns openly, believing in the power of a single word, knowing that sometimes less is more.
Up front, say, I'm worried about your kidney function. Because that word, worried, tells them so many things.
In addition to her medical career, Ginger has always valued authenticity. Coming out as an older woman, she found her true voice and never looked back.
I always felt I was authentic to myself, and what anybody knew or thought about me was a whole separate thing. Mm-hmm. So for me, coming out was not about being authentic, but for a lot of people, it is.
Ginger Campbell's medical milestones are matched by, of all things, her podcasting prowess, earning her a place in the Podcast Hall of Fame. Her journey is as inspiring as it is diverse. Born in Seattle and raised in the Rocket City of Huntsville, Alabama, she was influenced by her father's work on the Apollo program with Boeing.
I grew up, rooting for man to land on the moon. I've got first day Apollo 11 stamps. So I grew up in Huntsville. I was in Huntsville till 1977 and moved to Birmingham because my husband was an electrical engineering professor at UAB for 30 years.
Did you always know you wanted to be a doctor?
Well, not really. I mean, I thought about it when I was a teenager, but then I had a little side path that took me away from it. So I ended up in engineering and didn't decide to do it until actually the very end of my senior year. I was trying to figure out what I wanted to do. I thought that I wanted to be a researcher, a medical researcher, because I was here at UAB and medical research was the big thing, right?
Yeah.
And I had discovered that physiology was really interesting. So I was trying to decide, do I want to get a PhD? Do I want to go to medical school? To be honest with you, doctors had a lot more influence back then. And so I thought, yeah, I'll go to medical school. That's the way to go.
Obviously, with your husband working at UAB, there was a direct tie to go to UAB. So the decision was kind of obvious for you?
Yeah, I got in on something called early decision. I don't know if they still have that, but if you had a certain grade point average and whatnot, and you promised you would go to UAB, they would tell you like 6 months before they told anybody else. It really took the stress off. In order to be considered for it, you had to pledge that if you were chosen, you would go. I don't know if they even still have that. So I didn't apply anywhere else.
You wound up going the route of emergency physician. Was there something led you down that path? Did you just have the interest? And you wound up in rural Alabama for a bulk of your career for 2 decades. So was there something that wove its way for you that way?
It wasn't quite as planned as you might think, partly because at the time I went through, UAB didn't have a residency program in emergency medicine. And I actually went through medical school like a lot of people do, although they might not admit it out loud, of changing my mind, every 6 months. I think I started out thinking I wanted to be an anesthesiologist, although it's kind of hard to remember now. But yeah, thought about a lot of different things, really seriously considered going into general surgery. But I did a rotation at Shock Trauma, which is in Baltimore, and it was the first trauma center in the country. And, it was just surgery, go home, go sleep. And I realized that I'd rather actually have a life. Besides, back then, UAB's residents were on call every other night, literally, and they didn't go home at noon the next day. They just stayed and worked through. My husband said, if you go to UAB to train as a surgeon, we might as well just get divorced. But back then, we had two other big surgery training programs in Birmingham, so it wasn't really an issue. This was before Caraway closed.
Okay.
So I ended up doing what's called a transitional year. They may have changed the name of it by now. I don't know. The old-fashioned general intern year. And then I came back to UAB and taught biomedical engineering for 3.5 years before I finished my clinical training. And I did my clinical training actually in family medicine at Caraway. It was really good training for rural emergency medicine because people everywhere in Alabama use the emergency room as their safety net, but this is even more true in rural areas where there's like no pediatricians and things like that. I love the fact that every day was different. You never knew what was going to happen. I was not a classic emergency medicine doctor in that I wasn't into, let's, get them back from the clutches of death and do procedures, which is actually probably one reason why I changed to palliative medicine about 10 years ago.
Why the move to palliative care?
I think I would have done palliative care at the beginning if it had existed. It really fits my, palliative care is a lot about communication. And that's kind of really what I enjoy the most about being a doctor is talking to patients and helping them make choices. And that's what palliative care is really about, unlike what most people think it's about. We do symptom management and especially symptom management at end of life, but we spend a lot of time helping people make decisions about what's important to them. Do they want to have that 4th or 5th round of chemotherapy that might make them live longer but be sick the whole time? And of course, in the States, deciding, do they want to be resuscitated when they die? Those kinds of hard decisions, and just especially letting them know that they have choices. Because a lot of times people think that if it can be done, it should be done, and that they don't have a choice. So just helping them know they have choices. I found out about palliative care through a friend who's a psychologist at UAB's Palliative Care Center. And I thought about it for several years before I decided to make the leap, because it was really, okay, let's go and make half as much, work twice as hard, because I went back into training and did a fellowship. But I had also sort of decided I was going to leave the ER by the age of 60 because it's a young man's game. The hours are hard, but mainly because it really fits. Like I said, I'm not a classic ER doctor, despite the fact that I think I was a good one and I did it for many years. I don't fit the stereotype at all. I'm much closer to a stereotypical palliative care doctor.
I like how you brought up that you enjoy the communication. You like the communication between you and the patient. There's a stereotype that doctors, they're just, grizzly. They just tell you like it is, and they don't want to communicate. But that's a side of things that you find important. Why is that two-way street important with you and a patient?
I never thought about the why before, to be honest. But when I decided to go to medical school, my reason was, if I was sick, I would want to have a physician that I felt cared for me. I would want somebody to be there for me, that was an important thing. That was my reason for going into medicine, was to be that person that's there for you when you're sick or whatever. There's a joke about palliative care that our procedure is the family meeting, because doctors get paid for procedures, and that our main operation or tool is words. Because one of the things in palliative medicine that we do is we really focus on how people react to words to use, words to not use, which unfortunately most medical students aren't given any guidance. But it's funny because when we get green fellows that come to us, and they usually have had no rotations in palliative care, or maybe a day. But they already have that essence, that ability to communicate in that way. I mean, you can teach them how to do it better, but that gut feeling for it, I believe you can't teach. You can beat it out of people, I mean, the system used to be geared to beat it out of you. You know, they used to say, oh, you need to be all this separation from your patient and all that. But no, you need to care about your patient. And like, I'll give you an example of how this works with words. I always tell the residents at UAB, say, I'm worried about whatever you're worried about. Don't keep it in your head and then it happens later and you tell them and they wonder why you didn't do anything about it. No, up front say, I'm worried about your kidney function. Because that word worried tells them so many things. It tells them that you're worried, that this is serious, that they should be concerned, but it also, without saying it blatantly, says you care, because the word worry implies that I care about you, right? Mm-hmm. It's not doing it in a overly exaggerated way. It's just an understated way of communicating that. And that's an example of how one word can make a huge difference.
Did you know that going into medicine, that was going to be the case, or was it something that you had to develop?
It was interesting going into fellowship 30 years out of medical school, because obviously I had a lot of habits already. I already knew how to talk to people about hard things because I did that in the ER all the time. But I did learn how to do it much better. And that was we had a wonderful fellowship director named Michael Barnett, who had also done a medical education fellowship at Pittsburgh. And so he really was a great teacher. Like, for example, if we went to see a patient, he'd say, okay, what's the plan? Okay. When we come out, he'd say, well, he wouldn't ask us. Usually you're thinking, well, what went wrong? Because things never go the way you expect. But he always made us, well, what went well? He always made us talk about what went well before we, beat ourselves up about where we screwed up. And that was one of the things of being an ER doctor that was hard going into palliative medicine, because in the ER, you just go into the room, right? You usually have minimal information, vital signs. The chart may or may not have useful information. But in palliative medicine, you have to, know a little bit before you walk in there. And I sometimes don't do as much pre-research as I should before I still struggle with that, because of that habit of the flying by the seat of the pants that works in the ER is the wrong thing for palliative.
You are a talker, and along the way during your career in medicine, oh, by the way, you start doing podcasts. How did that all start for you? Because if I'm not mistaken, there's at least 3 podcasts to your record.
So I heard my first podcast back in 2005 when podcasts first appeared in iTunes. Back in the days of the iPod, before the iPhone, yep, where you had to, plug it in, USB, put it on your iPod. I mean, I knew I wanted to do it. I guess it spoke to my inner ham. And I don't mean ham radio. I mean, like an actor kind of ham. Of course, I did what people usually do. I recorded my voice in GarageBand because I'm a Mac person. And I thought, oh, this is horrible. So I just kind of put it away for about a year because I couldn't think of an idea. I didn't want a medical podcast because that would just be like work, right? But I had been, in around 2003, I started reading neuroscience. And so that was what I was reading. And back then, discussion forums were popular. Sure. Can you even remember?
Yep.
So I was on this discussion forum, and people would keep posting this stuff about the brain that was wrong. And I would post, if you just read so-and-so's book, you would know it's really blah. And so finally the host says, why don't you just do a book review for me for my show? So I did this book on intelligence by Jeff Hawkins. He's the guy who invented the Palm Pilot. And after he became a millionaire, he started some neuroscience institutes, and now he has something called Numenta, where he's trying to simulate the cerebral cortex. But anyway, his book was on intelligence. It's back, must have been published in 2005 or 6. Okay. And so I squashed this into this little 10-minute thing, which if you've ever listened to my show, I don't do short form. So that was a lot of work, but it was such a rush. I mean, I don't know how you feel about podcasting, but the first time I did it, I was like, oh, yeah. And I would never run out of material if I made a show about this. And this was back in the days of this website called the Podcast Pickle. Okay. And where you wanted to be rated in the Podcast Pickle because iTunes wasn't that big yet. So I'm naming my show. So I named it Brain Science Podcast. It used to have the name podcast in it because back then every podcast had the name podcast in it. But I picked Brain Science because of the alphabet. It was the old-fashioned, where are you in the phone book way of picking, right?
Sure.
Yeah. And yeah, I did that show for 17 years.
Wow. That's a good, I mean, that's almost 2 decades of content. How many downloads, how many listeners did you have?
That's a tricky question because they changed the way they measure it so many times. But I think when I quit producing regularly at the end of 2023. I think I had about 20,000 regular listeners. I probably had about 14 million downloads. I'd done over 200 episodes. My other show that I'd started actually at the same time as Brain Science was called Books and Ideas. And it was just where I put everything that didn't fit. Like I would interview science fiction writers, other kinds of scientists that weren't neuroscience people. I think I had at least one episode near the end about artificial intelligence. I know that's getting really hot. And then I did a show for 3 years called Grain Rainbows about coming out LGBTQ later in life. That was the shortest lived one because I felt like it was finished. Got a lot. It was very different. It was people sharing their stories and got a lot of really good stories on there.
When it comes to your production, what goes into an episode of one of your podcasts?
Okay, let's take Brain Science because obviously it's the one I did the longest. And I will say that, things have gotten easier.
Yeah.
Okay. So when I started, I would do everything. First, I'm usually going to be interviewing a scientist, usually a scientist who has written a book. I like to interview scientists who've written books because then the listener can go, oh, I want to know more. I can go and read this book. Also makes my research more manageable. So obviously I read the book and read the book again, and then go through and decide what I think are the key ideas, write my questions, which I rarely send out ahead of time because you need the spontaneity. And if you're interviewing somebody about their own material, they shouldn't need questions ahead of time unless English is not their first language, in which case I would do it. Then obviously record the interview. That's the fun part. Then edit, which for me would, if I interviewed for an hour, I was probably excessively fastidious, and every 10 minutes of content took about an hour to edit. I didn't actually put as much time into show notes as I probably should have, or much time into promo because, I started at a time when that wasn't really needed. And I had enough iTunes juice that people could find my show. If someone's looking for neuroscience, they can find it. So the editing was really time consuming. And about 10 years ago, I started paying people to do the audio editing. And that's at the point I was doing 3 shows, I was paying somebody to edit. Yeah. I could not have done that by myself.
In a previous life for me, I was in television and I always hated my voice. I didn't like listening to it. How long did it take you to get used to your voice?
Gosh. Well, the funny part is when I first started, I used to get these emails. I love your voice. I hate your voice. I could get you probably get this, right? You get on the same day, an email from someone telling you that they love your voice and another person telling you that they hate it, which is neither one of those is helpful. I guess when I started hearing people from outside the States, especially because, that's the great thing about podcasting. You hear from people all over.
Yeah.
I think I even had some downloads from Antarctica, which is the, pinnacle, right? But when I started hearing from people from outside the States that said, that they had a homey feeling when they heard my voice, I decided my voice was okay. And I also realized the fact that I don't talk super fast is helpful for people who are listening when English is not their first language, which is probably a large percentage of my listeners. So
You mentioned Graying Rainbows. It was the shortest lived podcast that you produced, but it was also the most personal. What
Yes.
led to that?
Well, I mentioned earlier that my husband died in 2015.
Mhm.
And actually, like 3 weeks after I finished my fellowship. So it was 2015 was a strange year. And later that same year, I turned 60. And I was thinking, you know, uh, I don't, I don't know if I want to spend the rest of my life alone. But I don't know that I necessarily want to marry another man. What does this mean? Yeah, right. But people don't realize how many people, come out later in life. And some of the issues they face are very different from the issues that younger people face. That was really the driving idea.
Talk about those challenges for you personally from when you came out and where you're at now.
I think for me, it wasn't particularly difficult because, first of all, I think I had a lot of people who just assumed I was gay even when I thought I was straight. So that, it's kind of like, oh, you finally figured it out. Oh, that's nice. And my parents were already gone. My siblings didn't care. I didn't have any family members, that I had to deal with. Unlike one guest I had who was a very Orthodox Jew, and to go to college, she actually had to sneak off in these clothes and then put on normal clothes and go to college until she could get to where she would be able to be independent. So I mean, I had most people had a lot more challenges than I, but I think, and I don't have any children. So I'll tell you that I think the two things I've heard the most are telling your spouse. Now, I had actually told my spouse when he was still alive, but he didn't really believe it, but that's neither here nor there. But telling your spouse and telling your children. People are really, really worried about their children, who usually handle it better than they think they will. And then the spouse. And then many people don't realize that a lot of people stay in marriages even though they may have decided that they're LGBTQ, because they still love their spouse, like I did. My husband was my best friend, and the fact that I might have done something differently if I hadn't married him was beside the point. Men in particular, I've gotten so many emails from men who are older men who are in those kinds of relationships where, their wife probably never worked. She's dependent on him. A lot of those people don't ever even tell their spouse, because put yourself in the place of the spouse, they can feel betrayed. They often do feel betrayed. And people don't want to do that to the person that they love. So that's my example of something that's very different for an older person who might be in a long-time relationship with a person that they do love. Right? That's a dilemma that a young person can't really identify with. On the other hand, the positive of being older is that you have your identity. You hopefully know who you are. And now it's true that there's a subset of older people who feel like they have not been authentic. Those are the people, and I'm just guessing here, I think might be more inclined to feel like they must come out. Whereas I always felt I was authentic to myself, and what anybody knew or thought about me was a whole separate thing. Mm-hmm. So for me, coming out was not about being authentic, but for a lot of people, it is. And so that's where it gets really, no matter what age you are, that's why the community makes such a big deal out of coming out. But that's why that's both important and difficult if you're an older person in a long-term relationship. And then people, no matter what age you are, people lose friends. They find out who, the funny thing, and I don't mean ha-ha funny, but strange, is that consistently people said the person that they thought would be supportive was not necessarily the person that was supportive. the person that they expected to be a problem was more supportive than they expected. The other lesson, really important lesson, is don't give up on someone based on their first reaction. Because people forget that you've probably been running this in your head for years before you come out, and you act as if they're supposed to be prepared, when more likely they haven't seen it coming. And then they react badly, and you decide, hey, that's how they're always going to act. That's not fair. Give them time. The best example I had was a woman who had been a Mormon, and her parents, who, clearly believed it was, horrible. But they never accepted that it was okay, but they came back to loving her as their daughter. But it took years. So if you have somebody in your life that you care about, give them room. Don't shut the door. Don't do something that is going to make a future impossible. Don't burn your bridges, as we used to say, because people need time. Maybe the people in my life were like, oh yeah, you just figured it out. But that's not how most people's families are. Most people's families are totally blindsided.
That's Ginger Campbell. Dr. Campbell earned her Master of Science in Engineering from the School of Engineering in 1980, followed by her Doctor of Medicine from the Heersink School of Medicine in 1984. 30 years later, she would complete her fellowship in hospice and palliative care. As a physician, writer, and podcast Hall of Famer, Dr. Campbell brings a unique perspective of what it means to be a Blazer.
It gives you a little bit of an underdog attitude, right? It's different from being from that other place. In a way, that's like here in New Zealand, where, the joke is we punch above our weight. New Zealand won 20 medals in the Olympics, and it has the same population as Alabama, about 5 million people. So, yeah, it's the parallels between Alabama and New Zealand are very interesting. But yeah, I say underdog.
Be sure to check out past episodes of the UAB Green and Told podcast. Listen in at alumni.uab.edu/Green and Told. Have a story to share or know someone who does? Email greenandtold@uab.edu. Finally, be sure to follow us on social media. Just search UAB Alumni on Facebook, Instagram, and Twitter. Thanks for listening, and until next time, go Blazers.